All right, welcome. Today, we're going to talk like we're on the floor, you and me. I'm the experienced nurse, you're the new grad, and we're going to tackle a heart rhythm that pops up all the time but can be kind of tricky. The premature junctional contraction, or PJC for short. Think of this as your personal crush course before you hit the telemetry station.
Okay, so picture this. You're at the monitor, staring at your patient's rhythm. It's looking good, nice and steady, and then, whoa, a beat just pops in there way too early. It totally messes up the pattern for a second. And then it happens again. You're probably thinking, what was that? And more importantly, do I need to do something? Well, that's exactly what we're going to break down.
So, what is a PJC? Let's get into the origin of this beat. That rogue beat you saw, that's our PJC. Basically, it's a heartbeat that jumps the gun. But here's the key. The signal to beat didn't come from the usual boss, the SA node. Nope. It came from a little further down the chain of command, from an area called the AV junction. Let's break down the name because it tells you everything you need to know. Premature means it's early, right? And junctional tells you exactly where it started, in that AV junction. Think of it like an overeager part of the heart that just can't wait its turn. Some irritable little spot in that junction decides to fire off its own signal, creating that random early beat you're seeing. Okay, now this is huge, especially for your exams, so pay close attention. You absolutely cannot get a PJC mixed up with a junctional escape beat. A PJC is impatient. It's an early bird that shows up unannounced. There's no pause before it. But an escape beat, that's a hero. It's a backup, a safety beat that only kicks in after a pause, when the SA node is taking too long. So one's an overeager interruption and the other is a life-saving rescue. Big difference. Okay, let's talk about reading the ECG, because this is where you'll spot the telltale signs of a PJC. To be 100% sure of what you're seeing, you've got to put on your detective hat. There are two main clues you're looking for on that rhythm strip: the timing of the beat and what the P wave is doing.
Now, the P wave is where things get really interesting, and it's the dead giveaway. Think about it. The signal is starting in the middle and traveling backwards up to the atria. So the P wave gets, well, weird. It can be totally hidden inside the big QRS complex, or it might show up after the QRS. And sometimes you'll see it right before the QRS, but it'll be flipped upside down, inverted. If you spot any of these weird P waves with an early beat, you've almost certainly found a PJC. All right, this little table here makes it super clear. A normal sinus beat, regular rhythm. But when a PJC pops in, the whole rhythm becomes irregular. Now, look at the P wave. Normal is upright and always before the QRS. With a PJC, it's inverted or gone or even shows up late. And that means the PR interval is either super short, less than 0.12 seconds, or you can't even measure it. The QRS complex itself, it looks totally normal. It just, arrived way too early. So, what are the causes? Why is this even happening? Okay, so you've spotted it. You're pretty sure it's a PJC. The next and maybe most important question a good nurse asks is, why? What's making that AV junction so irritable all of a sudden? Figuring that out is absolutely key to knowing what to do next. And lucky for us, there's a great little mnemonic to help you remember all the common causes. Just think of the word junction. Seriously, this will be a lifesaver for you both on your exams and when you're on the floor trying to figure things out quickly. So each letter stands for a potential cause you need to check. J is for junctional automaticity. Think Digoxin toxicity. U, using alcohol. N is for node injury, maybe from a recent surgery. C, congenital defects. T is for tobacco use. I is a huge one, imbalance of electrolytes. So you're going to want to check those potassium and magnesium levels. O is for oxygen deprivation, like from a heart attack or hypoxia. And finally, N, sometimes it just happens naturally in some patients. Okay, let's zoom in on that first letter, J, because digoxin toxicity is one of the most common causes of PJCs. This is a classic NCLEX question and something you'll definitely see in practice. Digoxin is known for making that AV junction extra irritable, and that can trigger these early beats.
So, if your patient is on dig and you suddenly start seeing a bunch of PJCs popping up on the monitor, your first move should be to check their latest dig level. Anything over 2.0 nanograms per milliliter, that is a big red flag. We're in toxic territory. You need to hold the next dose and get on the phone to the provider, like right away.
And here's another thing you absolutely have to burn into your brain for your exams and for real-life patient safety: the antidote. For severe digoxin toxicity, the antidote is DigiFab. You have to know that. It binds to the digoxin in the blood and neutralizes it. It's a lifesaver. All right, so let's ask the big question. When do we actually need to worry? I mean, is this just a benign little blip on the screen, or is it a serious warning sign? Your patient has PJCs. So what? How worried should you be?
Well, the good news is, a lot of the time, infrequent PJCs are totally harmless. If you just see one pop up every now and then and your patient is completely asymptomatic, they feel fine, it's usually not a big deal. We just chart it and keep an eye on things. But when those PJCs start showing up frequently, that's when our concern level shoots way up. Think about it. If the heart is firing off these early beats over and over, it doesn't have enough time to fill up with blood before it pumps. And what does that lead to? A drop in cardiac output. The heart just isn't pumping blood effectively anymore. And that's when you'll start to see symptoms. These are the red flags you have to be watching for. Chest pain, that fluttering feeling or palpitations, shortness of breath, dizziness, and especially a drop in blood pressure. If your patient starts complaining about any of these, those little PJCs just went from being an interesting observation to a real clinical problem. Okay, so let's get into your nursing plan. From assessment to action. You're seeing frequent PJCs. Your patient is symptomatic. Now what? You have to have a plan. Here's what you do. Okay, here are your top 4 nursing priorities, and the order here is crucial. Step 1, assess your patient. Not the monitor, the person. Get a set of vitals, ask them how they're feeling. Step 2, investigate the cause. Go through that junction mnemonic in your head. Check their meds, their labs, their history. Step 3, then you notify the provider, but you do it with all your assessment data in hand. And step 4, educate the patient, especially about those risk factors they can change. And don't underestimate your role in patient education. This is where we can make a huge difference. Simple things, right? Talking about smoking cessation, maybe cutting back on the caffeine and alcohol, even just staying hydrated to help keep electrolytes balanced. These simple lifestyle changes can dramatically reduce how often these PJCs happen. Now, talking to your patient about this is so important. They see that monitor, they see the alarms, and they get scared. Your job is to be calm and clear. You could say something like, I can see you're concerned about the monitor. We're seeing some early heartbeats, which can be common. I'm here to watch you closely, and we'll be looking into why they're happening. It's simple, it's honest, and it's reassuring. It shows them you're in control. So, let's wrap this up with the single most important thing to remember. The big takeaway is this. Treat the patient, not the monitor. That ECG strip tells you what's happening electrically, but your patient tells you how it feels. When that little blip on the screen turns into dizziness or chest pain, that's when it becomes a clinical priority. Always connect the dots between the strip and the person. That's what makes you a great nurse.